Thank you so much for inviting me to join you this evening and to celebrate this 2021 Global Health Catalyst Summit. I've been witness to several years of the success of Will and other students and colleagues. And I want to congratulate you on all you've managed to accomplish, all you've managed to do, the more than 1,000 people you've managed to train around the world, the educational centers that you've helped to put forward. And I also have the special privilege of being able to congratulate Dr. Harold Varmus on receiving this year's Global Health Catalyst Award, and to say how important it has been to be able to count on a Global Health and Cancer Institute at our National Cancer Institute. It was founded just over 10 years ago, thanks to the vision and dedication to global health and global cancer of you, Dr. Varmus. And we're happy, so happy to be able to celebrate those 10 years, this decade of work, but also all of us are thrilled and very grateful to count on that center as a place from which we can get support and engage in so much of the work that we do globally. With that, I'd like to share a presentation with you this evening. And I decided, since it really is an evening, that we would do something that was a little bit less academic and data oriented, and just sort of tell the story of collaborations that began from a very special moment for me, the moment when I found out that I had breast cancer. So let's go over to the presentation. That I'm so happy to be able to share with you this evening. So this is me in June of 2007. I'm standing in front of a painting that's very important to our family. It was painted by my then 11-year-old, now 26-year-old Hannah Sophia. And she painted this vision of her mother. But so much of the health and well-being and joy in life came from my hair. And as a family, just a few months after that picture was painted and displayed, our family came together around my very unexpected breast cancer diagnosis at age 41 in my first baseline mammogram. At that point, I also had a 3.5-year-old, Mariana Javiva, as you see her here with me, one day after treatment, tired, but together. We had no idea that this would come. There was no family history. There was no reason to assume that there would be a diagnosis of breast cancer. And when this diagnosis came through, I had all of my work going on as a researcher. I had not worked very much in cancer, but I had worked significantly on health systems. We were based in Mexico. The Seguro Popular had been launched a few years prior by my husband. And so I was heavily entrenched in research work on breast cancer. This diagnosis certainly stopped our family for a little while and myself in my tracks, but relatively soon we managed to do what you see Mariana doing in this photo, which is to just laugh at this disease, scream at it when it was necessary, and move forward in many different ways. I lived this disease with my husband, Dr. Julio Frank, who had just completed in 2007 6 years as Minister of Health with President Fox and established the Seguro Popular. And we talked about the difference between, in his case, leading a health system and both of us learning about a health system versus living a health system. And really together, he got into that, as you can see, that bed with me, where I'm receiving a transfusion. And we had to think about what it meant for families, for women to have to transit the difficult process of a cancer diagnosis and treatment, even with the sorts of resources that we had, both financial and access to care, and how difficult and what this would be for so many women who didn't have this kind of access. I wrote about this journey first in Spanish as Tomate la Pecho, and then in English as Beauty Without the Breast. And that book transitions us through much of the process that we lived through as a family and myself, as a patient on this journey, but also how we came to do work on health systems. Now, when I was first diagnosed, there was depression, there was a decision on my part not to accept treatment, particularly chemotherapy. And this went on for weeks, if not months. But there was this moment, this epiphany in my case, where I realized that there were so many women in Mexico still who didn't have that choice, that luxury of saying, I wonder if I'll have care or not, either because they didn't have access to care, despite the fact that Seguro Popular had just begun to cover for everyone the care, or they didn't have anyone to take care of their children while they were going through the process of this diagnosis. And that inspired me to use the skills I had as a researcher to begin to look at the data and ask, well, is there anything that I can do? Can I use my disease, our experience, to be able to think about moving the needle forward on breast cancer initially? And we went to work looking at the data, working with researchers and colleagues at the Instituto Nacional de Salud Pública based in Cuernavaca, the National Institute of Public Health, and with the Mexican Health Foundation. I know we're speaking about collaborations here, so I wanted to highlight those. One, a research institute that gives master's and PhD degrees in public health, well-established, decades old, and the other, the Mexican Health Foundation, a 35-year-old non-governmental organization that also undertakes research on systems, a very strong NGO based also in Mexico City. We worked together, we looked at data, we brought together colleagues, and we found something we really didn't expect, which is what you see in this figure. We were able to trace data on mortality, and that's with my colleagues, primarily Hector Ariola. We looked at trends in mortality from 1955 to, in that case, around 2005, 2007. And what we saw was this switch where breast cancer was taking over for cervical cancer, that more women were dying of breast cancer than of cervical cancer. And we, in fact, were very surprised because we had thought that cervical cancer, being supposedly the disease of poor women, and breast cancer, the disease of rich, we never thought we would see this. Yet you see this inversion. And we also saw this incredible peak in 1985, 1988, of 16 per 100,000 women dying of cervical cancer, and then this incredible decline, which also spoke to us. We looked across the country and we saw that in wealthier states, in this case at the top, you see Mexico City and Jalisco, this crossover had happened decades before and no one had realized it. And then in poorer states like Puebla or Oaxaca, it was beginning to happen. The gap was beginning to close. But either way, there were many Mexican women dying of breast cancer. And we were able to document that, very concerning to all of us, the number 2 cause of death among young women in their 30s, 40s, in premenopausal ages in Mexico, the second leading cause of death being breast cancer. That brought us to start a program called Tómatelo a Pecho, and then to make that program become a non-governmental organization. Tómatelo a Pecho in Spanish literally means take it to breast. It was my husband, Julio Frank, who helped to form this NGO, who baptized it with this name, this ingenious name. There's no direct translation into English, other than the idea of taking it to heart, taking it seriously, realizing that this is a priority. So we set up initially a program and then established a non-governmental organization, formally based in Mexico, an Asociación Civil, legally registered, between 2008 and 2011. We worked in a very collaborative way. I wanted to highlight this report that we did in 2009, 2010, Cáncer de Mama a Conciencia. It's to be conscious, to take seriously, again, this idea of breast cancer. But I highlight was on the back cover because we worked across non-governmental organizations based in this case in the Mexican Health Foundation. We worked with reproductive health organizations like MexFam, the IPPF Mexico group. And so we had 16 different organizations participating in this, what we called the Reporte Rosa, the pink report for 2009, 2010. These organizations in Mexico later came together and formed a coalition that is very operative and active in Mexico called Comesana. We were able to, as a set of NGOs, representatives of civil society, hand this report to the then First Lady, Margarita Zavala, now a senator, and say how much we needed done on breast cancer. We were also able to pull in leaders like the person you see, probably to your right, my left, Maki Esther Ortiz, who at that point was Undersecretary of Health and was incredibly important, instrumental in ensuring this Seguro Popular would cover all women for breast cancer treatment. Maki herself being a breast cancer survivor. This is the kind of advocacy we were able to do, but it was because we were working as a group across 16 different organizations in Mexico. We then, having thought about what was going on in the country, decided that there was an incredible opportunity to work with health promoters. And we began to bring together large groups. In this case, again, health promoters, very little formal training. This is a training that happened at the National Institute of Public Health, again, in Cuernavaca. And we then worked with nursing students and medical students, but working with them meant undertaking research around a set of materials to help to promote initially earlier detection, so breast clinical examination, but also to better accompany the patient in treatment, in survivorship, and if they require palliative care at a primary level of care. We worked with the Harvard Chichana School of Public Health, where I was then based, and the Harvard Medical School with Dr. Nancy Keating, and we published in the Oncologist. I can't highlight enough how important it is to publish results, but working together again with the Mexican Health Foundation, with the National Institute of Public Health, and with Tomatelo Pecho, we were able to show that we could train a group of health promoters with very little, again, formal or clinical education to effectively understand the disease and to understand how to undertake breast clinical examination. We published not only in English, but in Spanish. And again, this is a very important lesson learned. We published locally in the Journal of the National Institute of Public Health, Salud Pública de México, in different magazines, and in a series of different journals, again, in Spanish and in English, to guarantee that there was a sharing of knowledge. In all this process, we were struck by the myths around breast cancer. Not only in Mexico, but globally. That it's the disease of high-income countries, which is not the case. It's the disease of older women, also not the case. The majority, at least in low and middle-income countries, are under age 55, that it's a lower priority than cervical cancer. I already showed you that that's not the case, and globally, it's also not the case. Only in the poorest regions of the world are more women dying of cervical than breast cancer. So both are a priority. And then this terrible idea that breast cancer is an incurable fatal disease, that is not the case if diagnosed correctly, if diagnosed early, and if there's access to appropriate treatment. It is a very curable disease. We have data from the American Cancer Society that suggests a 99% 5-year survival rate with early detection and appropriate access to treatment, which is not obviously what we see in low and middle income countries. Based on that set of ideas around the myths for breast cancer and the need to integrate into health systems, by that point, based at Harvard University, and myself in the medical school, and my husband in the School of Public Health, we were able to work with a set of leaders, some of whom had been my mentors and teachers, in this case, Nobel laureate Amartya Sen, a cancer survivor himself. We were able to undertake a set of global pieces of work on breast cancer, breaking down many of these myths. But that work on breast cancer led to something much larger. We realized that there was a global cancer issue, but the ways to go at it were thinking about health systems. And so we brought together global health and health systems leaders, like here, my husband Julio Frank, Peter Piot, Paul Farmer, with experts in cancer care and advocates working in cancer care, Mary Gasparowicz from Princess Margaret Cancer Center in Canada, in Toronto, Princess Dina Mired, who then went on to head the UICC, and we got together and from Harvard formed a global task force on expanded access to cancer care and control in low and middle income countries. We published a paper in The Lancet in 2009 on expansion of care. And this is where we met and began to work with Will and Christian and other wonderful early career researchers at the time who have done so much since then. And we published a book, Closing the Cancer Divide. About 115 different authors representing tens of scores of countries from around the world. And we were also able to produce several pieces of this material in several languages, including Spanish, and there was a Russian translation. We published that with Harvard University, but again, with a large group of researchers, including early career researchers and students from around the world. Now, I was still continue to and work often in Mexico when we're not in the middle of a pandemic. And I was undertaking additional projects like this one, trying to bring cancer care delivery innovations so that it would be closer to home for women and they wouldn't have to travel so far. And it was on a visit to one of the hospitals about 2.5 hours from Guadalajara, where I came to meet this patient. And we thought that we had provided an opportunity for her to receive her chemotherapy in this second level hospital in this small city. But when we came in, we realized that in fact, this woman was in the last stages of her life. She was dying. And I was with my oncologist, Dr. Julie Graylow, who's now leading the research areas at ASCO, I'm proud to say. And Julie helped me to understand what we were seeing with this patient. And I asked the head of the hospital to please, provide support for palliative care. And the answer was, no, we cannot do that. She was not even in pain. She didn't need morphine. She needed basic support, her and her 17-year-old daughter. And what they said was she must be transferred to the capital city where there's a tertiary level hospital. That was not what she needed. She needed to be transferred home and provide support in a dying process. And it was at that moment that I began to realize that we had sort of made this terrible mistake. We had done the Seguro Popular, we had declared universal health coverage, but we had left out palliative care and pain relief. And it was that realization in Mexico, and then bringing myself back to an experience many years prior with my own father dying of cancer in Toronto in Mount Sinai Hospital, where I had to beg for additional morphine, additional pain relief medication, additional opioids to calm the pain that he was expressing he had. And in the end, that I was the one who administered a good part of that dose at age 18, that then finally led him the next morning to pass in peace. I had held that sort of a secret with me, knowing at the time what it had meant to have had to do this. And as I began to understand more of this missing link in palliative care and pain relief, reached out to my colleague at Harvard and Franda Tulgawande, who had been working at that time on this amazing book, Being Mortal, Medicine and What Matters in the End. And it was with the tool that I talked about this experience in Canada. And he brought me up to speed on what it meant to really think about palliative care and the support of those in pain at end of life. That all came together into another Lancet Commission on pain relief and palliative care. They produced a major report. Christian was a big part of the work that was done on this report. And again, we went diagonal and brought together health systems and global health leaders with palliative care specialists, 33 commissioners, and there were 61 co-authors from over 25 countries, again, including many early career researchers who participated in this commission that I had the honor of co-chairing with Dr. Paul Farmer. And it was called a landmark report by Richard Horton, editor-in-chief of The Lancet. And one of the reasons, and there were many, was that we included testimony and information from women like these two that I met in our National Cancer Institute. The woman to your right, the older woman, that's her daughter, was dying in tremendous pain from a cervical cancer, but she didn't even have the capacity to, the words to be able to express the pain, in part because she didn't speak Spanish. And they were there finally after months of her being in this situation at the hospital, beginning to seek pain relief. Luckily for them, in Celia Allende's group at the National Cancer Institute, able to think finally of what it meant to gain support. But we brought this together with data and projected it in what I think were somewhat unusual and effective ways. This map was sort of the hallmark of the report. Here we're looking at the need for palliative care and pain relief the need for pain relief or palliative care, excuse me, measured in serious health-related suffering, measured in people. That was a new measure that we brought forward. And we're looking at distributed opioid morphine equivalent, which is all the opioids that could be used for palliative care brought down into a morphine equivalent number. The bottom line is what you see in this set of maps is an engorged Canada, US, and Australia, Western Europe about the size we think it should be, because pain relief is not only for palliative care, trauma, childbirth, mental, many others, but the rest of the world disappears, and that's the point you need to focus on. Russia is a small flat line, China the same, India a small vertical line, Africa virtually disappears, and Latin America is kind of a small blip over there on the right-hand side below the United States. And that is because 50% poorest of our world have 1% of the morphine, and the richest 10% have 90% of the morphine equivalent. This was one of the most heinous and inequitable distributions that any of us as commissioners had ever seen. We spent a lot of time working on this data. We were able to show that one could provide the necessary morphine because we focused on morphine, the cheap generic kind, off patent, immediately released oral and injectable morphine. We said that at current prices, closing that divide and only measuring again just the medication, but that's extremely important, $600 million. And that if poor countries who tend to pay much more than rich could get the prices that the rich countries have, the only 145 million, this is a tiny amount of money compared to global health budgets. For example, $145 million is about the annual budget of a mid-sized hospital in the United States. Yet we don't have it. Yet we have children dying in pain with cancer all over the world. And this is a situation about which much can be done. But again, let's go back to this issue of collaborations. We would never have been so successful, nor would we have been able to carry out any of our recommendations had we not been able to work extremely closely with the International Association for Hospice and Palliative Care. And I'm proud to say that I'm now on their board. We also worked with those that developed the World Hospice and Palliative Care Day, the World Hospice and Palliative Care Alliance, with the International Children's Palliative Care Network, and with the International Narcotics Control Board, with the World Health Organization, with others. In fact, for palliative care, there is a huge and impressive network of organizations around the world, probably stronger than anything I ever have seen in cancer. And we work closely with them. Again, if not, we would have no platform to be able to push through these recommendations. I wanted to briefly tell you that we are now working on an update paper. We have a picture in terms of the data that go from 1990 now to 2019. We can look across countries. We can show the distribution, in this case, of 6 different kinds of opioids. And this is using data from the International Narcotic Control Board. If these were not shared, if these were not available, we wouldn't be able to share results like this. Now, what's happening now? We have just launched a new Lancet Commission on Cancer and Health Systems. I am honored and proud to say that my co-chairs are Dr. Mary Gospodarowicz from Toronto and Dr. Patricia Garcia from Peru, former Minister of Health. The announcement came out just a couple of months ago. We'll be having our first major set of meetings beginning next week. And we said that we're confronted with both a challenge and an opportunity to raise the bar for cancer control for everyone, everywhere, and that our commission takes up this gauntlet. What we are trying to look at here is, again, this diagonal approach. We want to see how better cancer care can improve health systems for all, and how better health systems are necessary for more and better access to cancer care, and how this all comes together to ensure universal health coverage and to ensure universal access to cancer care and control. We suggest that getting cancer right is, in fact, a pathway to improving health systems universally. And that's what we'll be working on for the coming 2 years, we hope. I want to close with this because when we think about a problem as big as a global pain divide, as big as a global cancer divide, it can sometimes feel tremendously overwhelming. But we've been working more and more towards what I've been calling economics of hope. We have seen so much change in global cancer, so much that has gotten better, that should make us think that we have to make our decisions, our investments, based on a better world, what the world can be, what we've seen with cervical cancer and an HPV vaccine, rather than on a pessimistic world. And I end with this personal experience because I think it does really speak to this. In my last infusion, I got septicemia. And as many of you will know, septicemia really can kill you and really can kill you almost immediately. And that morning, when I said goodbye to Mariana, our little one, again, 3.5, 4 by then, and was rushed to the hospital, it was that one time that I thought, after a 1.5 years of intensive cancer treatment, that I might be saying goodbye to her. Yeah, and I was treated in Mexico, wonderful physicians at one of our best hospitals. And with that access, in 1 week, I was much better. And in fact, where I was then in Toronto in a butterfly farm with Marianita. And, you know, I share that a bald, unwell mother is hard for a little girl to be around, to see. It's frightening. And so my baldness was never something that was easy until that day in the butterfly garden, where because of the hat, all the butterflies came to me. And there was that moment when the photo came, when she was comfortable, when she was with me, when this piece of terrible pain and fear really came together into a beautiful, wonderful moment. And I always use that of my way of sharing and ending these presentations around how we can close global pain divides, how we can close global cancer divides, and to thank you because all of you, and particularly under Will's leadership and guidance, and with Christians as well, have done so much to be able to make this a reality for so many people. And I know that this is only the 5th, 6th year, if I'm right, in what will be decades and lifetimes of work to continue to close cancer divides. So my thanks for allowing me to join you tonight. I wish it could have been in person, and I hope it will be again next year. All best.